Okay, well, good morning, everyone. It's a pleasure to be here. I'd like to thank you all for coming, and also the 160 we have joining us virtually this morning. It's a great pleasure to welcome you to this session on increasing access to cancer control in low to middle income countries, organised by the International Atomic Energy Agency and co-hosted by the UICC and the Lancet Oncology. My name's David Collingridge. I'm the Editor-in-Chief of the Lancet Oncology. And we've got an esteemed panel here on stage today who I'll introduce in a few moments. But I think first it'd be useful for me to set the scene, because this is a slightly different topic for this forum at World Economic Forum. Now, low to middle income countries have long suffered from high morbidity and mortality driven by infectious disease, malnutrition, and poor maternal and child health. But the growing incidence of cancer, a disease that affects now 1 in 2 in high-income countries, is an increasing challenge that most nations are ill-equipped to tackle. This double burden of disease is a consequence of lifestyle and behavioural changes, a shift in population demographics to an ageing population, and factors caused by globalisation, genetics, infection, political and social instability, and environmental factors such as climate change. The health of people in lower income countries where fragile health systems are under-resourced and under-financed also find themselves understaffed, and this needs to be of global concern. Stigma from a diagnosis of cancer is also an unnecessary blight, coupled with the lack of trust in health systems. It reinforces the perception that cancer diagnosis is an inevitable and irreversible life-limiting event. Regrettably, this view is not without substance. Seen through the lens of the inequities in early access to diagnosis and treatment between rich and poor citizens of the world, the cost of cancer care, both at the macro and micro level, can be catastrophic. Furthermore, most of our evidence is based on research done in high-income countries and in large white populations. It typically does not take into account the large variation in global cancer demography, gender, or the realities of access to care for patients living in rural areas versus those in urban centres. These are all big drivers of the disparity of cancer outcome. By 2030, there will be a need to double the expenditure on cancer care if we're to tackle the existing shortages in resourcing of treatment centres, prevention and public health, and strengthening of multidisciplinary workforces. Now, later in this session, you'll have a chance to ask questions of the panel. But I think first I'll just introduce the panel and we'll have a few rounds of questions before we get to that. So joining me on the stage today, to my immediate left, we're very delighted to have Rafael Grossi. Dr. Grossi is the Director General of the International Atomic Energy Agency. He assumed office as the 6th Director General on the 3rd December in 2019, and last year was reappointed for a second term. Dr. Grossi is a diplomat with almost 40 years of experience in the fields of non-proliferation and disarmament. In 2013, he was appointed Ambassador of Argentina to Austria and the Argentine representative to the IAEA and other Vienna-based international organizations. He holds a PhD in International Relations, International History and Politics from the University of Geneva, from where he also received his master's degree. Next to Dr. Grossi, we have a slight change in the panel this morning, as you might have noticed. Unfortunately, Dr. Isabel Mestres was unable to make it, but we have a brilliant replacement, Miss Maggie Rariera. And Maggie is the Global Partnership Director at AMREF Health Africa. She's a leader in advocating for environmental and social issues, and she brings a unique perspective to the realm of non-communicable diseases. Her commitment to the intersection of climate change and health suggests a holistic understanding of public well-being. And I'm sure we're going to hear more in those areas from her shortly. And at the far end, and probably needs no introduction in certain circles, we have Dr. Carrie Adams, the CEO of the Union for International Cancer Control. Born in London, Dr. Adams has a degree in economics, computing and statistics from the University of Bath, and a master's in business administration. He's a Harvard Business School alumni, attending the school's Executive General Management Program in 2003. In 2009, Dr. Adams made a career change, moving from the management of international businesses in the banking sector to become CEO of the UICC, based here in Switzerland in Geneva. Dr. Adams and his team focus on global advocacy, convening the cancer community through large platforms such as the World Cancer Day, the World Cancer Congress, and the World Cancer Leaders Summit. Collectively, Dr. Adams' organization runs a significant global capacity building projects, a number of projects in this area, and address global cancer issues. So this is our panel today. I'm going to start the debate this morning, turning to Dr. Grossi. And the question I'd like to ask you first is, in general terms, what do you see are the key challenges to improve cancer control in low to middle income countries? And why is it important to have this event here in Davos?
Well, good morning. Thank you, David, Mike, Gary, for joining us today, and people in attendance, some of whom we've been working already with, and all those who are connected. It is to take the second part of your question. I think in and by itself, the fact that for the first time, there is an event on cancer, and specifically, I would say, with a very pointed aspect of human health in this gathering, which is normally associated with other things, very important, undoubtedly, but closer to economic development, finance, industry. I think that in and by itself is an indication of the efforts that our community, and when I say our community, I include all of us here present and connected, are starting to yield some result, even at the level of being heard, and a certain understanding of the many issues that are being discussed across the town cannot be fully comprehended and realized and brought to real fruition if we continue to, I wouldn't say ignore, but not deal with the world cancer crisis in the way it has to. I have seen, and we have seen, that there is some adoption. Let's see to what extent there is a full incorporation of the some of the jargon of the Sustainable Development Goals and other more global, I would say, preoccupations in some of the discussions that I am attending, because I am attending a number of events, in mirroring the agenda of the IAEA, which goes from nuclear non-proliferation and nuclear weapons to nuclear energy and what is happening in the markets to this. But I would like David to start with that notion that it is important that we as a international cancer care community are here, and that we are having the possibility to start a dialogue and to start looking for the solutions we need. If we have this kind of forum, is because we do have a problem. And this community here is aware of that, and I wouldn't need to regurgitate some of the things we know. It's not necessary for me to repeat dismal statistics, because we know of the gaps that exist, in particular in low and medium income countries. So I think it's enormously important that we are having these intersections at this level here, knowing full well that we need to deliver on so many fronts. So this would be a first thought I would like to share with you. The second is that having to do with the problems and the issues connected with treatment, connected with availability of equipment, connected with, and I'm sure we will be discussing this, with workforce, capacity building and training, etc., is what prompted me early in my time as Director General to launch Rays of Hope. Rays of Hope is not reinventing the wheel, but it is about tackling this issue with approaches that are commensurate to the problem we are facing, and including all the actors, private sector, global health institutions, the IAEA, society, communities in countries in a different way. Why? Because either we are not getting the results we should be aspiring to get, or the problem is getting bigger. And so you can see it in these two different ways. But it's clear that we need this boost, this big boost in what we are doing, and our effort is about that.
Thank you very much for that. And some good thoughts there, and particularly around engagement and partnership. That's why we're here. And perhaps turning to you, Maggie, your organisation has had a lot of experience of partnerships, and a lot of progress has been made in many lower income countries through partnerships. Perhaps you could give us an example or two of some of the successful partnerships your organisation, AMREF, has had in cancer control.
Thank you very much, and good morning, everyone. Yes, I'm the last-minute addition to this panel, but indeed, I do want to say a little bit about AMREF Health Africa, for those who may not know it. AMREF Health Africa is the largest African-led, African NGO that operates in the health sector and has programmatic presence in 35 African countries. And our commitment and our vision is around lasting health change. We see the realities of how things affect health that are outside of the health sector. Over 75% of the things that affect the health outcomes of our communities are outside of the health sector. And we look at how do we drive solutions and work with partners around it. So our solutions are based on both non-communicable and communicable diseases. And I want to go straight to your answer around an example of what we did in the area of cancer management. It was a broader program on NCD, but we were also looking specifically at cancer. So this was in 2019, between 2019 and 2022, and we worked with Takeda. This was a public-private partnerships that was looking at how can we improve quality of life and survival. In, as you mentioned earlier, in rural Africa, it's hard for people to access healthcare, basic healthcare. Now, when you go to other areas of health, like cancer care, it gets even worse because things like detection, our health systems, our healthcare community workers, as well as health workers, are not equipped for that. They're used to communicable diseases, so the detection is a big problem. Further to that, actually having equipment, diagnostic equipment, is another issue. Affordability, chemo, or requiring any other interventions is beyond the cost of most of the population that's there. So we were looking at how do we increase survival, because technically most of the patients, by the time they actually come, chances of survival are very low. So many people choose not to go. They choose to just opt out and give up. So we were looking at survival and quality of life. And so what we did was address the very first important one, which is the capacity of the health workforce, and also how can we equip healthcare facilities with some of the right equipment. And then particularly, we work very closely with the governments of the countries we're in, as well as the communities. We have to get both stakeholders on the table. And but this particular project was done in a county in Kenya where the Ministry of Health had identified that the patients there had little access to critical care. So they wanted to look at what kind of interventions can be brought there. And so we formed a consortium, and as AMREF, we led this consortium of partners, some of them from very local community-based organizations, as well as the NCD Alliance Kenya. And we were looking at disease surveillance as one of the key things, access to quality care. We're looking at how do we bring products and even equipment to this community and to the health services that are provided to them, and just building community awareness. And we ended up having about 3,000 healthcare workforce trained in this time, both in the prevention, detection, and even management of palliative care. We looked at supply chain management because there were stockouts. There were constantly stockouts of, medication that was needed, and working with the procurement officers, were able to reduce that by 35%. Further to this uptake, because now we got the community involved and engaged, we had a 400% uptake in people taking chemotherapy when they were required for that. And then we went beyond that and looked at the social economic conditions there and what could be done by the government to help some of the most vulnerable, poorest community members. And 26% were actually able to access a national health insurance that could enable them to continue seeking care and even be able to pay for some of the services. Thank you.
Thank you, Maggie. There's some really important points there if we unpack that. You mentioned obviously that people with late-stage disease won't even attempt to access medicine. That's a big challenge, I think, in many countries, but particularly in Africa, where there's a lack of access to opioids and morphine and pain medication. I think you also touched on a very good point around, actually we should be looking at this issue. It's not a cost on the public purse. This is an investment. A healthy population is a productive population, right? So it's an investment. But you also mentioned there about training all the workforce. There's a lot of issues there, and I think coming to Carrie's organisation is about advocating for change and actually working on the ground at doing that in some cases. So perhaps, Carrie, you could give a little bit of an overview of the mission of the UICC and how you advocate for change.
Sure, thanks very much, David. So the UICC is a non-government organisation based in Geneva, Switzerland, and we work in formal relations with the WHO and IAEA and also IARC as well in Lyon. UICC is nearly 1,200 organisations who are working in 170 countries. And our role is to work with them to ensure that they can do the best they can possibly do in their country, working with governments and working with partners to implement good cancer control at a national level. So part of our role at the centre is education, sharing best practice, running training, fellowships, to ensure that those organisations have the best knowledge possible, which is available from us, often taken our guide from the likes of WHO, where we know the best buys, for example, in the full spectrum of cancer control, whether that be tobacco control all the way to use of palliative care, as you mentioned earlier. So a lot of our work is with those organisations, helping them do what they're trying to do in their country, whether that be in your country, or it be in Spain, or whether it be in the USA, it doesn't matter. However, on their behalf, we do advocate for change. And one of the things that we do is work with others to advocate to make sure that health is on the global health and development agenda, but also the Davos agenda, Rafael, to make sure that businesses around the world understand the importance of health, what is happening in low and middle income countries, and how, as a collective working in partnership, we can resolve the challenges which you so beautifully articulated. Because everything you said there cannot be resolved by one organisation. It's got to work in partnership. So we have a Siemens in the room, Siemens Healthineers, whether we have Avarian or Electa, whether we have Pfizer, Novartis, we have expert groups like ASCO, ASCP, Direct Relief, IDA Foundation. Collectively, we have to work together to resolve the challenges we face. This is a complex problem, which unfortunately demands complexity in the solution. We've got to address some big international barriers, like a broken business ecosystem, which means it's difficult for businesses to justify the investment to go into low middle income countries. How do we break those barriers down? How do we assure them that they can do it at a reasonable return, but not outpriced so that no one can get hold of the medicines or the technologies? And that demands collaboration. So UICC over the years has worked with different organizations on different initiatives and projects on how do we address those common problems that are needed to be dealt with in order to give patients in those countries the opportunity to be diagnosed correctly and early and be treated well and survive. So yes, it's a big issue for all of us.
Thanks, Carrie. It's certainly a big challenge, that's for sure. And perhaps if I just return to you, Dr. Grossi, on you mentioned the Rays of Hope.
Yeah.
And this was a big initiative. You launched it at the Africa Union Summit, I believe, last year, 2022.
Yes.
And of course, it needs a lot of support from heads of state.
Yeah.
Political buy-in is one of the big challenges we have in the global cancer community.
Yeah.
Can you tell us about the role those political partners play?
Yes. Well, it's essential. It's essential because of the complexity of the problem. It's not something that you are going to be solving by looking at the specifically healthcare side of it, or the money side of it, or the technological side of it. You need a unique set of arrays that are going to be making this there, and of course the public health sector is indispensable because we need new facilities, and this is part of the problem. We need to put those existing up to speed, which in many cases are completely off track, and all of that needs political commitment. We know that on everything we need governments and we need understanding from them. The case of race, we are trying to do something different, which would be assuming that to a certain degree getting political pronouncements is not impossible. We've seen so many of those at different levels, UN level, WHO level, even IAEA level, G20, G7. So it is not so difficult that the problem, the health problems are recognized and given some space. Where we see a gap is when it comes to action. And there we clearly see that there is an element which is missing, because even when we see in the case of multilateral institutions that are better endowed, like the European Union, for example, because one thing is, if other gatherings say something, but the European Union, they have, through the Commission, they are committing billions sometimes. And when I read that, then I have some difficulty in finding where this money is. At least for our cancer community, we don't see that. I'm not saying it's not happening, but what we need is more connection and an immediate delivery. We are able, in contact and in collaboration with some of your institutions, and this is what my Rays of Hope team back in Vienna is delivering. We are able to produce cancer intelligence, which is available elsewhere, but we do it in a context where we do have, through our technical cooperation program, a very clear visibility of what is happening in different countries, what kinds of things they really have, what are the things that they may not having. So to have this very effective channel, that is what is really missing. And this is what made us design Rays of Hope in the way which is designed. namely by having a variable geometry approach to countries depending on what we see. And the definition of countries which are pure beneficiaries, countries that are playing both roles, and this is where the concept of the anchor centers come into play. When we go to Africa, we have Kenya, we have Morocco, we have countries that do have capacities and capabilities which need to be supported, but they are also reverberating and being platforms for further help in neighboring areas. So this is what RAISE is trying to bring, and what we are trying to illuminate to world leaders. So they open the doors that need to be open. It is clear that the political decision level is indispensable. Without it, we will be swimming in circles. And this is one of the things I recognized. Rays of Hope, again, I would repeat, is not reinventing the wheel. The story did not start with us, but what we saw, at least from the IAEA side, was that we were not having the impact that was needed. There was a lot of work.
Yeah.
No doubt about it. Project here, project there, but we were not really moving the needle in terms of this. On the contrary, we see the statistics, and again, I will refrain from start throwing at you figures that you know. I mean, it's growing exponentially, death rates as well. So this is where we are trying to tackle a problem that we know in a way that we have not been doing so far.
No, thank you for that. A kind of a follow-on question to that, I guess, is, it's not easy, but it's not impossible to get governments to say they're supporting something. But what levers do you think the IAEA and us as the cancer community can really move to hold these governments to account to actually deliver on their promises?
Well, I think, first of all, there is something that we can bring to the table, and not to make this approach an approach that is being seen as censoring governments, or as something that is aimed at putting governments under the limelight and make them feel bad. No, we want them to work with us, and to do that you have to, and this is where the art of the international health diplomacy, if I can call it like that, can play a role by designing products, if I can call Rays of Hope a product, vehicles, channels that are what they may be needing in order to bring this to the to hospitals, to health centers, and so on and so forth. Okay. You have the level of the political commitment, yes. You may even have the level of money, and even the private sector saying we want to help, or we could be helping. But what, in my opinion, was lacking was this integration of all these factors under one umbrella, which is what we are trying to do.
Okay, great. And Carrie, did you want to add to that?
Yeah, if I could build on that, I think political engagement is absolutely critical. I'm an optimist, and I'm very positive about global commitments. I think World Health Assembly resolutions, UN high-level meetings, outcomes documents are important. They're important because they are commitments, and they can be used by national cancer organizations to advocate for. If a country signs up to do X, it gives a lot of energy to that community in that country to say, right, you've signed up to that, what are we going to do about it? In terms of converting to action, I think you're right, Rafael. It's our job, almost like civil society's role, to convert it to action. It's our responsibility to follow up. And I think following up is that every country should have a robust and funded national cancer control plan. if not standalone within an NCD plan. I think that then converts it from a member state commitment to a country commitment. Because often the plan goes well beyond a government's life. And that commitment sets out very clearly what the priorities are for that country and how they're going to be funded, whatever the funding mechanism may be. But it also gives an opportunity for us as the international community to say where we can help. You know, so Raise for Life, that comes in to help on that aspect of radiotherapy. The Atom Coalition, which we've set up, comes in to help on the medicines delivery and diagnostics. The McCabe Law Centre comes in to help on how to get law passed in order to make sure that the tobacco industry does not stop laws going in place on tobacco control. So the international community can help countries and the cancer organisations to implement, to follow through on those commitments which hopefully the head of state, it could be my health minister, but the head of state has made to the issue of cancer in their country. And of course at the end of that period, once the NCPCP has been completed for 5-7 years, we then have an opportunity to reflect on what went well, what went badly, where the gaps are, where the opportunities are, and then we can galvanise a second commitment. So I think that it all needs to be put together as a package, but the role of the international community is to help countries to implement what is important to them within their own communities.
Thank you very much. And I think we've heard quite a bit this morning now around the need for public-private partnership. You know, we can't achieve all of this with the public purse, and nor should we in some regards. Now in the audience, we've actually got commercial sector who are going to give us the insights that we need in this area. And I'd like to just call out Mr. Darren Back, who's CEO of the Pfizer Foundation and Vice President of Pfizer. Perhaps you could share some thoughts with us, Darren, on public-private partnerships. Particularly, we're talking about national cancer control plans. They're so important. Perhaps some thoughts.
Can you hear me? Okay,
Yep.
Perfect. Thank you, panelists. I'm very pleased and grateful that we're having this much-needed conversation, especially at WEF, because we've needed it for a long time. For us at Pfizer, addressing the oncology burden is a huge priority. And actually 2 years ago at WEF, we launched an initiative called An Accord for a Healthier World, where we committed to provide all of our medicines and vaccines on a not-for-profit basis to 45 low and lower middle income countries around the world. But as we've discussed, access to medicines is just one small portion, right, of the pie, and we're all very much aware of the barriers. And so I just wanted to touch on something, Rafael, that you said about looking at this differently. And I think from our perspective, really this is what we're seeing starting to happen now and what we really need to lean into. And from a private sector perspective, it's very much around how do we engage in a different way, because we all bring unique resources, expertise to the table. We've been working with Bern's team at Siemens Healthineers to explore, what are those opportunities when we look at the burden of oncology. But we've been doing this for a long time, so we need to think about how do we do it differently. And that's why I'm grateful, Kerry, for coalitions like Atom, because I think that provides us an opportunity to come together and look at this in a very different way. And the great work of AMREF, it's looking at the entire patient journey from, as you said, stigma, screening, all the way through to patient navigation and even sort of end stage care. So I think for us, that's the key priority, but everything very much needs to be, as you said, Kerry, government-led. It needs to fit within a national action plan.
Yes.
And really, I think it's our responsibility to help ministries of health change that dialogue, right? They know there is this huge burden, but as you said, Rafael, changing the dialogue, talking about the opportunity, what's saved, the investment, what it means from a socioeconomic perspective, helping government see that opportunity and making those policy changes. So I'm very grateful for the discussion, and I'm looking forward to hearing more.
May I immediately react to that?
Yes,
because it's a very, very valid point, and I thank you. And of course, having Pfizer on board is an incredible opportunity. We have 70 countries have signed up for Race of Hope. 70 countries at official level, which is what you are meaning. I mean, knowing that there is a problem in some country does not mean that you can do something. So 70 countries, 40 in Africa. So this is why, I started in Africa. I launched RAISE. Some of member states from my own region were saying, hey, is this for us? Well, no, it's not. It doesn't mean that we're not working in the Caribbean, in some parts of South America, in some parts of Asia as well. But the dimension of the problem, as your work is proving, is there. So what we provide is that. I mean, apart from many other things. So we sit down with the countries at their level. And mind you, your comment is very interesting, because when I was starting with Rays of Hope, President of the World Bank, David Malpass, this is what we need. We need these kinds of things to be integrated and fully integrated in the national cancer strategies and plan, and this is also part. I don't want to get bureaucratic here, but this is part of what we do with impact missions and things like that. I don't want to get too much into that, but indeed, this is, and what we want is to have a program that is so flexible that we, and this is something I'm telling my private sector partners like Siemens or you and Elect and Varian and all these people is, I mean, you put your finger on the map and I will have something there. Because of the dimension of the problem. Make it your, if Pfizer wants to be active in Southern Africa or in this or that island in the Caribbean, I'm sure they have signed up for RACE. And so there is an ongoing active Rays of Hope program going on, I'm sure, in the places where you might like to be, because here again this is also part of the need for effective partnerships that are win-wins. I hate the expression, but for lack of another, let's use it, because you have your priorities, the corporation world and corporative world has its own social responsibility priorities, and we can easily adjust to that. There's no problem. What we want is to start solving real problems and getting some of these projects really going on. So I think this is exactly the philosophy, and we look really forward to working with you guys. Yeah.
Thank you, Rafael. Just also in the audience, we've got Bernd Montag, who's CEO of Siemens Healthineers. And perhaps, Bernd, you could pick up on this point about radiation oncology and how we deliver affordable radiation oncology in lower income settings.
Yeah, thank you for the question. I mean, maybe I start a little bit broader, yeah, because I believe what is the challenge when the discussion in the LMICs switches from infectious disease to non-communicable diseases. Yeah, I believe that there's one big. But why is the challenge in a way bigger? Yeah. So, and I'm talking as a layman. Yeah. So you correct me. Yeah? I mean, on the one hand, NCDs and especially cancer is a personalized disease. Yeah. So it requires personalized treatment at scale. Yeah. While to some extent, with all due respect, yeah, when it comes to fighting an infectious disease, yeah, the vaccination and so on, this is typically a one-size-fits-all treatment in a way, yeah, which is not easy to implement, yeah, but at least it doesn't require personalization at scale. And the second challenge, I think, especially in cancer care, is that cancer care always is a team sport, so to say, of diagnosis, treatment, aftercare, and tricky enough, in many cases, multiple treatments, multiple sources, the chemo, the radiation therapy, and so on and so on. So, and what it means for a company like us, which is very much about cancer care, is a combination of Siemens Healthineers and now Varian as part of it, is, I think what it requires for us to do is, on the one hand, currently we traditionally are a company which is inspired by those who have it all. That means MD Anderson, Memorial Sloan, yeah, the big cancer research centers. Yeah, this is a big source of inspiration and of innovation. But what we need to learn is to get inspired by those who don't have it. Yeah, and to target innovation and to take pride to make things simple and affordable. So this is one big topic. Yeah, but it's a real mindset shift. And then when it comes to this topic of ecosystem, yeah, or partnerships, which was discussed, the mindset shift we are undergoing here is, yeah, we are in our, let's say, high-income country incarnation. We are spoiled by the ecosystem existing. Yeah, and our role is very clear. We are the equipment provider. I don't like the word. Yeah, but there is the institution, there is the reimbursement, there is the electricity, there is the trained physician and everything. Yeah. So, but we cannot wait for this to happen in LMIC. So our role is changing completely by being an active builder of the ecosystem. Yeah. And this means for us not only doing, let's say, low-end innovation, yeah, or but to change who we are in becoming a partner, in reaching out. Yeah, we do partnerships with, with Rays of Hope. Yeah, the IAEA. I'm very excited about the partnership we have with City Cancer Challenge, and so on. Yeah, where it's really about how can we active contributor in building up the partnerships. Like we're also exploring what we can do with Pfizer. We cannot just lay back and wait until the ecosystem is there. We need to actively do this. Yeah? And I think the third topic is a big one, which is also a mindset shift, yeah, which bears fruit over time. A company like us, typically, you grow up in a company like this, and you look at success is how often have you placed the equipment? How many Linux did we sell? Yeah, so instead of how many lives have we impacted?
Exactly.
Yeah, and I think there's one big learning, maybe a global learning from the pandemic. Everybody looked at what's the vaccination rate, what's the infection rate. Everybody looked at the Johns Hopkins dashboards. Yeah. So this topic, yeah, measuring really what's the impact,
yeah,
and not only what is the current business model, what you get paid for, is the other big thing we are working on. So I think we are making progress. I don't say we work on water, but I think we made the first 10% on a very long journey. Yeah.
Thank you, Bernd. And I agree, we need to be looking at patient outcomes. That's what we're all here about to achieve. And the WHO has the cancer scorecard, and I think this is something we should perhaps be developing a little bit more as a community. But building a little bit more on this public-private partnership, perhaps turning to you, Maggie, and your experience in Kenya, but also more broadly across sub-Saharan Africa, what do you see are the main priorities in that public-private partnership space in the short and medium term?
Thank you. Thank you for that question. And I want to carry off from where he left off. You talked about co-creation and finding solutions that are homegrown and working there. I'll give an example of one of these handheld devices that was delivered. Yes, it make it easier for our community health workers to be able to do some of the diagnostics, etc. But it was developed in the more developed countries. But by the time it came to Kenya, unfortunately, not much consideration was given about where it would be stored and locked. So the community health worker carries it home with him instead of leaving it at the hospital. If anything should happen there, you've lost your equipment. Further to that, if any kind of repairs are needed, no skills in managing that. And then other issues about electricity and the use of certain things that are not taken into the local context when this lovely innovation is made elsewhere. So it is crucial to bring in the voice, the knowledge, and the understanding from the community that would help to actually produce innovations that will take us a long way. So the co-creation part is absolutely critical. You did talk about governance and just risk management, because when you get into these partnerships, and we're seeing even within AMREF, how can we evolve more from a grant-based system to results-based financing? So it takes us to a slightly different area, but we need to look at what are the risks and how will we manage the partners that are there. I talked about a consortium that had 7 different partners, government and others. And it was critical to understand from the start, what is our shared vision, and then where are we not aligning? And an uncomfortable conversation on certain areas that you realize, okay, can we go ahead knowing that this and this isn't going to work for everyone? You talked about not liking win-win, but what do you see as the contribution that each of the partners is going to bring that is of value to the initiative you're taking? And where is it not necessary? And sometimes you do say, okay, maybe this partnership, we should let it go, or because what the partner wants and what we want to do is not going to take us to the same place. And then capacity building and knowledge sharing. I mean, this was something that we did, and we've seen that it worked in one county, and we're seeing how we can escalate it and make it work in other places. What is it about this model that we can take and lead in other areas where we're seeing cancer management is failing? Within Kenya and outside, we are in 35 countries, so African countries, how do we help them set up models like this? So how do we build that knowledge and not let it just sit there? Yeah. And what is the role of the different partners in also driving that across where they work? It might be in countries where we're not. Thank you.
No, thank you. And Carrie, turn to you. You've mentioned a few partnerships the UICC have sort of spun out from the main organisation over the years. The ATOM initiative, the McCabe Centre for Cancer and Law, which is really a rather unique enterprise, and City Challenge. I wonder if you just tell us all a little bit, elaborate a little bit more on those 3 things briefly.
Yeah, sure. So UICC, as I said, is an NGO, which is a very close remit, working for its membership as a membership organisation. But what we have done over the last 14 years is we've identified either problems which exist at the global level that need to be resolved through a different vehicle, or opportunities which exist which could be addressed through a different vehicle, not UICC. And by bringing organisations together, we've been able to release new organisations which have a very tight remit, addressing something where impact can be achieved. As Rafael said, we need impact. So the City Cancer Challenge, for example, was launched here in 2017. And then it became a standalone foundation run by Isabel and a very able board. And it's working brilliantly today with 14 cities, growing to 20 in the next couple of years, working from the bottom up with local communities, finding the issues that are important to them, and then bringing the international community in to resolve those issues in a holistic way. The McCabe Centre for Law and Cancer works with governments, the health minister, who often has 1 lawyer working for them, maybe 2 if they're lucky, and they're trying to put in the laws which cover cancer control, from risk factors through to, for example, labelling of food, anything which could affect health. And so training them up and creating a network of nearly 250 lawyers around the world that know each other, share best practice to get laws through. Because, as Rafael said, you can get the words from the health minister, they're committed to something, but once they try and put a law in place, it's hard, it's complicated. How do we do that? An ATOM coalition, which we formed 2 years ago in May, is to bring those who are passionate about getting medicines like Pfizer, like Novartis, getting their medicines into countries that don't have access to novel medicines or even the essential basic medicines on the essential medicines list. How do we collectively bring that expertise together to address that problem which is affecting everyone? And these are solutions that are working today, and they are sustainable long-term solutions because they're embedded in a self-funding organisation which can do it through the appropriate governance structure we put in place, and not rely on UICC to be there longer term. So we're putting in place business solutions, working with civil society, that actually make a difference and have impact in the longer term.
No, absolutely. And I think we're hearing that this is a very complex space. Cancer control is extremely complex. And perhaps just one more question for Rafael, and then I'll open up questions from the floor. But do you think the complexity of cancer control is something that's just really off-putting for investment, and is one of the drivers of lesser investment in cancer and oncology services than perhaps in other areas of healthcare?
No.
No?
No, I don't think so. I think there is a recognition of the complexity.
Yep.
And this is something that, and to a certain extent, we need to put that message across very clearly. I would admit, at the same time, not simplify things by pretending that it's a straightforward thing, as it was said before. But at the same time, cancer coalesces like few things, and this is something that we have to bear in mind. It has, perhaps not to the extent because of the drama about COVID-19, which was affecting us in such a direct, we were, told not to go out, we saw people dying, etc. Still, the statistics show that cancer is much worse in terms of lives, in terms of, but still, you need that. So the complexity, I think, is recognized. But I think we have, I am optimistic. I'm basically optimistic because I see that we are all working together. We all have the same sort of approach, and I don't see any piece of the puzzle being missing. We have academia, we have the NGOs, we have the big companies, we have international organizations. We can have the political decision-making power. The issue is here to put the puzzle together, and this is the thing. The pieces are there. It's not that we are ignoring anything. So I think that. The difficulty of the problem is understood, but I don't see that as an impediment or as a showstopper, if I can put it like that.
I'm loving your enthusiasm. This is great. This is great.
Well, you need that. Otherwise, you never get anything done.
Exactly. Perhaps I'll open up for questions in the room. If anyone has a question for the panel, if they can stick their hand up. We've got roaming mics. And just say who you are and what organisation you represent. Yes, lady at the front. Can you bring the mic
We have
here,
a
please?
question here.
Hi, I'm Cecil Moore. Worked 12 years. Red Onk. I have a question for Maggie. I'd love to hear, because of your experience, and you quoted this project on cancer. Can you maybe comment on the challenges you might have seen in the area of cancer versus non-cancer communicable diseases? Because I guess that's what we're here for, to talk about, and love to hear from your voice on the ground. So what are the differences you have seen in implementing programs, maybe the hurdles or opportunities, cancers versus other type of disease in your area? Thank you.
Okay. Thanks for that question. I think I'll start from just the structure and the system. From a systems perspective, our healthcare systems and the people trained to run them have primarily looked at infectious diseases as the first thing that comes in. So the mentality coming from just the mental framework is that infectious diseases are what you're going to see. So there's already a blind spot in how it is approached. And so there's that shifting that needs to be done. And then the patient journey is something that has not yet, it's fairly straightforward, I'd say, and you mentioned it, for infectious diseases, it's fairly straightforward in the management, and it's well documented. Within the area of NCDs and cancer, we're still mapping out, and we're missing so much information. So we're lacking data that could help us build some credible cases of what are the interventions and how often they're taken, just from even the healthcare workers recording certain things and helping us to start build a case of this is happening more in this area, and then going back to other factors. Is it the food? What could be the other externalities that are coming in? So it's more direct to see, okay, malaria, you should do this, versus is it the food people are eating, what are they being exposed to, that could be leading to this. So connecting those is a big challenge, and we're still trying to build data around it.
Thank you very much. I'm being told we're quite tight on time, so if anyone has other questions, you can certainly speak to us after the session. But I'm going to turn to Carrie, just 1 minute, final thoughts to wrap up what we've heard over the last hour today.
I think funding is a big issue. We haven't really touched that. It's a major issue. I think there are opportunities for increasing funding into low-income countries. It would be lovely if the likes of the Global Fund were able to allocate more money to health systems improvement and move away slightly from communicable. That would help. But that's not going to be the answer. I think governments have got to somehow be able to raise funds in low-income countries, but we're in a debt crisis at the moment. There's very little funding space available. There are more low-income countries in a debt crisis today than there was 10 years ago. And the cost of borrowing for those countries is extraordinary. So if we want accountability at a national level, we as a community have to see how can we get funding for health into countries where the cost of borrowing is so high they can't even pay for the borrowing they've had in the past. So there are bigger issues that need to be taken forward, probably by Davos and others in the finance groups, in the G20 and others, that are going to release the debt burden by reallocation or in some way swapping, so that we can give those countries the chance to invest in their own health systems rather than repaying the debt burden, which is getting out of control once again.
Good, well made point, Carrie. Maggie, final thoughts from yourself?
I think I want to piggyback on what he said, which is really what are the innovative financing models that we will be able to use, even as NGOs. What are the ways we can look around this to make sure that care is given to the most vulnerable? And how do we package that, as you said, to different audiences? Yes, there's the Global Fund and the big donors that we typically go to, but from the business perspective, we are starting to look at how do we make it a solution that's attractive for the organization, but is also good for the community. And that's why I mentioned earlier that we're looking at results-based financing models as one of the ways to help us deliver sustainable health solutions within the community. Thank you.
Yeah, well made. And Dr. Grossi, just finally for yourself, how do we continue this conversation and continue this engagement with the Davos community?
Well, a little less conversation, a little more action.
Very good. Very good. Well made. So I'd like to thank you all for coming. And if you could, round of applause for our esteemed panel today.
And thank you, David. Thank you very much.
Thank you.
And thank you again.
When I was younger, I thought that the people knew that nothing has price, that nothing has price. But all is clear, now I can conceal that years have gone down